Please read it. If you have a chance, it will reinforce and increase our knowledge about this topic to better advocate in favor of the affected Louisville communities. Remember, Dr. Quinn from Louisville Metropolitan from the School of Public Health came and presented. As of September 19, the Center for Disease Control and Prevention Advisory Committee on Immunization Practices, ACIP, unanimously recommended that vaccination for COVID-19 be determined by individual decision-making. Please contact your health care provider, talk to your doctors. This is an invitation to our whole community to be mindful and follow the vaccination schedule recommended by the American Academy of Pediatrics for all children, the Kentucky Department for Public Health, the fall immunization guidance for providers with guides for everybody, the American College of Obstetricians and Gynecologists, guides for specifically for immunization during pregnancy. It is important to keep in mind the safety and the well-being of the whole community. Let's remember, people who are unvaccinated are at higher risk of getting these preventable diseases, and they may have a higher chance to get hospitalized and to have complications. According to the organizational and operating rules of the Louisville and Jefferson County Board of Health, the positions of chair and vice chair have terms of 1 year. Dr. Eccles and I were elected in July 2024. There's a need for election, but it will delay until all the appointments are announced. The mayor's office is still working on them, and the election will happen as soon as possible. So today, for our perspective session this month, which title is Fluoride in Drinking Water, we have Dr. James Randy Ransdell, DMG, MAGD, who was appointed to the Louisville Metro Public Health and Wellness Board of Health in 2024. He completed his studies at St. X High School, DePaul University, and the University of Louisville Dental School. After a residency in the University of Kentucky, he opened his first dental practice in Louisville in 1989. While serving as president of the Louisville Dental Society in 2014, he co-founded the Louisville Free Smiles Clinic, which in conjunction with the Family Community Clinic continues to provide free dental services to the underserved Metro Louisville population. He was awarded the Humanitarian of the Year by the Academy of General Dentistry in 2019 for this work, and he is married and has two sons. Today, I present to you Dr. James Randy Ransdell, DMG. Welcome, Dr. Ransdell. If you have your presentation, and you would like to share, you can do so at this time. I yield the floor to you.
Well, thank you all very much for being here, and I welcome this opportunity. Catalina, if you could bring up the presentation, and it's fairly involved, and I'll try to get through it as quickly as possible. My voice yesterday was almost non-existent, so I'm hoping my wife made me some tea, so I'm hoping it's a little bit better today. But the topic is publicly fluoridated water, the pros and cons, and I'd like to thank you, Dr. Patricia, for the suggestion to explore both the pros and cons of public water fluoridation, because in this exploration of new studies and research and information, new viewpoints might be formed. I have practiced in the golden age of public water fluoridation and have been inculcated in the benefits of fluoridated water. My earlier research confirmed my biases. I had not looked into the more recent data and studies questioning the safety and ethics of community water fluoridation. And I kind of felt that those that were anti-fluoride people were either crackpots or at least eccentric. Stay tuned, and I hope this next information provides provocation for discussion of this important issue. Next slide. Little background, in 1901, a dental school graduate named Frederick McKay opened a dental practice in Colorado Springs, and he found many of the residents had grotesque brown stains on their teeth, but found few dental caries. Fast forward, Alcoa chemist H.V. Churchill tested the water near a bauxite plant where residents had the same stain and found high levels of fluoride in the water. and his colleague later made the jump. Dr. H.T. Dean postulated that small amounts of fluoride in the water supplies might help decrease the caries rate. At 4 p.m. on January 25th in 1945 in Grand Rapids, Michigan, it became the first city to experience optimally fluoridated water. They were chosen because they had a low natural fluoridation level and a high population of children. After just 11 years, Dr. Dean, who is now director of the NIDR, announced an amazing finding. The caries rate among the children born after the fluoride was added dropped more than 60%. Today, 65+% of U.S. public water supply is now fluoridated, and the initial decrease in dental caries was dramatic. Next. This will cover the pros to public water fluoridation and the thesis statement. This is the pros are what I cut my teeth on, pardon the pun. Public water fluoridation has been, for the last 80 years, the foundation of improved oral health, decreased dental pain and cavities, and improved productivity, all delivered in a cost-effective and universal beverage. Next. Prior to 1900, around 113 studies on the effectiveness of artificial water fluoridation were conducted in 23 countries and had a general decrease of 40 to 60% decrease of caries rate in primary and permanent teeth. A later review that went up to 2010 in 10 countries, it was not older adults, but children through 44 years of age, produced reductions of 30 to 50% in primary and permanent teeth. But the fluoride action in the prevention of dental caries was predominantly found to be post-eruptive and topical. Next. It has great public health effectiveness. It reduces tooth decay. The most recent study says about 25%. It reaches all residents. As a community-wide measure, it provides all residents served by a public water system, regardless of age, income, or access to dental care. And it's a passive intervention. Excuse me. It decreases oral health disparities by providing benefits regardless of socioeconomic status, and it has a proven track record. The U.S. Centers for Disease Control and Prevention named community water fluoridation one of the 10 great public health achievements of the 20th century. The practice has a long history of safety and effectively improving oral health outcomes. Next. It is cost effective and has economic benefits. The cost of fluoridating water is excuse me. After the initial investment, the cost of fluoridating water is quite low. There is significant cost savings for communities over 1,000 people. Every dollar invested saves an average of $38 in dental treatment costs. This number has varied over the years and it ranges from $38 to $20, but this saves money for both the families and the healthcare system. It prevents missed work and school dates by preventing toothaches and other dental illnesses. 2025 study by Harvard University in the JAMA Health Forum said eliminating fluoride would add $9.8 billion over the next 5 years in additional healthcare costs and increases after that. It was based on a computer model relying on human bias and antiquated data from 2013 to 16. Next. It has a strong safety record. According to the earlier studies, for more than 75 years, it has consistently shown that fluoridation is safe when maintained at optimal levels. It has overwhelming endorsement. Community fluoride is endorsed by more than 100 health organizations, including the ADA, the AMA in the World Health Organization. Something else that I found that I thought was very interesting, Calgary, Canada voted to remove fluoride from its water in 2011 due to the cost of it. And it is a city, I think, of about 1.4 million people. In 2024, it was reintroduced due to increased incidence in dental care and emergencies, especially in children. Next. Now, here are the cons to public water fluoridation. The addition of fluoride to public drinking water is an outdated, unethical, and potentially harmful mass medication practice that should be discontinued in favor of proven and targeted alternatives to dental health. Next. Ethical issues. There is a lack of informed consent. It's a form of mass medication that violates individual rights. Informed consent was not emphasized when I graduated. It is very much expected now. This practice of water fluoridation contradicts the prevailing trends in modern medical care, which emphasize targeted therapies, personalized medicine, and the importance of informed consent. Next. There's no individual dosing. And again, to revisit, there is the necessity of ingestion of fluoride is ineffective. The water fluoridation has a one-size-fits-all approach, and it varies on people's body weight and age, activity level, and health, and their thirst. It's infants especially that are bottle-fed fluoridated water. They have an impaired ability to excrete fluoride and receive up to 400% more fluoride per pound of body weight than adults. As I said earlier, it is found to be ineffective in ingesting it. The effects are topical, not systemic. Next. Impact on poor populations and rising fluorosis rates. There's disproportionate impact on the poor because they may be less able to avoid avoidance measures like filtered or bottled water and are often targeted for fluoridation. The CDC has found rising fluorosis rates in adolescents in the United States, and the recommended levels they're saying are not adequate to prevent overexposure. Next. This to me was the most concerning one. Neurotoxicity concerns, and many studies showed a 3 to 5% or 3 to 5 point decrease in IQ. Most recent studies have indicated a link between high fluoride exposure and neurotoxic effects, including lower IQ in children. There was a recent US federal court ruling in California acknowledging an unreasonable risk of reduced IQ, and it has further fueled the controversy. There have been over the years 7 meta-analyses that found statistically significant inverse associations between fluoride assessment and measures and children's IQ. One of the larger ones in November 2019, the National Toxicology Program released a draft report, and I think they updated it several years later. It's about 200 pages long, and I did read it. It would be the ADA president was cited as this study reinforcing the safety of fluoride. I was hard pressed to read it and have come to the same conclusion. I came to the conclusion that fluoride in the water would likely be detrimental to one's health. Next. The science against water fluoridation. And they graded all of the studies that they analyzed, and I'm sorry, I can't remember the total number, but out of that, they found 18 of 19 high quality that were low risk of bias, and 46 of 52 that had a higher risk of bias that supported the premise that children, that it caused an inverse association between the estimated fluoride exposure and IQ. The findings of these studies consistently provide evidence of an inverse association. And something again that I found interesting is they also had, it was in inclusion or absence of other covariants such as smoking, the inclusion of lead, mercury, manganese, PFA, and arsenic concentrations. They didn't substantially alter the associations with the IQ. And they said that they conclude that there's a moderate confidence in the body of evidence that estimated fluoride exposure is inversely associated with IQ in children. Next. There's also additional effects that were reported in the literature. Chronic long-term overexposure has been linked to potential harm in the thyroid and skeletal system. There was a study in Scotland that addressed dementia. Osteosarcoma is a pretty rare disease. Thyroid cancers are more common, but in several studies, it was noted that in areas that did have fluoridated water, there were increases in both of these diseases. Next. Water contaminant risk. Industrial grade chemicals that are used for fluoridation, they can be contaminated with other chemicals like lead and arsenic. The concentrations are typically regulated, but it does potentially introduce some of these into our water supply. The fluorides are the only chemicals added to public water supply that are not intended to improve the safety or potability of drinking water. And the caustic nature of these fluoridation chemicals leads to the introduction of an additional chemical, orthophosphate, to the water to decrease this caustic nature. Next. Topical fluoride application. Modern dental care emphasizes topical application through fluoridated toothpaste, mouth rinses, and professional fluoride treatments. A lot of people think that this renders mass water fluoridation obsolete. There's also been a general increase in improved oral hygiene over the last several decades. From a global perspective, 95% of the Earth's population do not fluoridate their water and still have seen similar declines in tooth decay, suggesting that fluoride is not necessary for good dental health. I feel that studies need to be completed measuring the ingestion of fluoride while using topical delivery methods. I could not find any studies addressing this. Next slide. And come to the question, how effective is fluoridated water? The studies are not super well documented. The Cochrane study, which widely is cited by water fluoridation supporters, identified only 22 studies of acceptable quality in children and none in adults. This is despite the claims that in some places you'll see there are thousands of studies proclaiming the effectiveness of fluoridated water. The research cutoff on this study was 2023, so it didn't include the Lotus study of over 6 million adults in England, and it was published in January 2024. It was the largest, strongest study of fluoridation effectiveness in adults ever done, and found a very small benefit, lifetime reduction of decay of only 2%. Next. Recent studies seem to show a much reduced benefit versus the older studies. Studies from the 70s found reductions of up to 5 cavities per child. That benefit has decreased rapidly, and the most recent study, which was the Lotus study, found a reduction of only 0.16 lesions per child. I found this interesting. It was by the public health outfit in England, and it was ironically the same government agency trying to expand fluoride to all of England. Next. In reading this, it kind of led me to think of the parallels to some other harmful substances that have been, our exposures have been recommended to be decreased or eliminated. And it took 20 years after the discovery of absolute lead toxicity for the EPA to ban it from ingestion. They just kept changing and lowering the levels over the period of time, well after the evidence was compelling. And I just am curious, is this what's happening with fluoride? Next. When I went into this, I always asked the question, who is benefiting the most from this? And obviously people who have a decreased carries rate have benefited, but financially there's about 5 different people or 5 different groups: chemical suppliers, chemical distribution companies, engineering and consulting firms, and public health institutions who don't profit directly, but they receive funding and lobbying support advocating fluoridation. There's grant funding, dental research, sponsorships, other things as well. A 5th one is the regulatory capture and waste disposal avoidance. The fluoridation sidesteps toxic waste laws. It's estimated that $130 to $170 million a year are gained from fluoride sales directly to the company. It's unknown about the support businesses, and billions are potentially saved in hazardous waste disposal. There was a recent fine and court case with a company called Mosaic, who's a fertilizer maker. And in my notes, I have some additional details about that. Next slide. Why should fluoride be removed from the water? Basic logic tells us that while a cavity can easily be filled and repaired, damage to a child's brain is lifelong and irreversible, and there are no second chances. Next slide. In conclusion, I think it's time to look more closely at the current data that's available. We can't rely on the legacy information that was circulating 10 to 20 years ago. The science is compelling that public water fluoridation carries more risks than it originally imagined. While there are undeniable public health benefits, it supports unsound medical ethics as well. There are better fluoride delivery alternatives in the vast majority of well-supported studies showing medical IQ risk make one question if the risk of public water fluoridation is now worth the benefit. And next slide. I appreciate your time and attention and putting up with my growly voice. If anybody has any questions or wants a copy, I actually had a little different copy of this than what was shown, but they can email me. I have notes with most of the citations, if not all of them. Email me at ransdell@yahoo.com. And again, this was an eye-opening journey for me, and I appreciate the opportunity. Dr. Patricia, thank you.
Thank you very much, Dr. Randy. This has been an eye-opening presentation, and I know my brain and probably a lot of the brains present at this meeting are just going, wow.
Yeah,
I'm
me
gonna
too.
give, I know, so now I'm opening the floor for questioning or comments. Does anybody have a question?
Dr. Randy, this is Dr. Shah. It was definitely
Yes.
a very eye-opening presentation, 100%. But one of my questions was, have they ever looked at countries that fluorinate versus countries that don't, and the impact of IQ on that? Is it been done that way?
Yes, and a lot of the more recent studies that were done, from what my memory tells me, they were done in, for the most part, non-fluoridated countries, and the people that they were analyzing for the most part had fluoride levels that were far above, or even not necessarily far, but they were above what was recommended. But the thing that was troubling to me is this increase of or decrease in IQ. It was pretty much a linear relationship all the way down. So I find it hard to believe without further research that, you know, it even our recommended levels of fluoridation could be problematic. So, but yes, and as I said, there was a slide that was left out of there, or I don't know if it was left out. I changed my presentation and I thought it was going to be the one on my screen, but it instead of being the one of the top 10 public health or top 10 public health
benefits
or triumphs of the 20th century, it actually, out of 194 countries, there's only 24 that use artificially fluoridated water, and only 10 of those have the majority of their population that are fluoridated. And like 95% of the world does not have artificially fluoridated water. And none of the Asian countries, China, India, Japan, only 4 in Europe, and it might be 5. I'm not exactly sure what Britain has proposed, but it's in none of Africa. There's one African nation that's fluoridated. I mean, for the rest of the world, it's really not an issue.
Thank you.
Wow.
Sure.
Thank you. Anybody else?
Yes, Dr. Randall, Marta Sanchez with Gilda's Club. I was looking up information while you were giving the presentation, and it says that the recommended level for drinking water is 0.7 parts per million.
Yes, ma'am.
Do you know when this was established? Because as you mentioned, relying on legacy. Is this something?
That's a great question, and I didn't really look into this, and if somebody has the information out, and again with any of this that would refute it or bolster it or whatever, I would love to hear from you. But the benchmark of the WHO is actually a range, and I think it's 0.5 to 1.5 depending on people's activity levels and their climate, where they live, and things like that. The FDA has chosen the benchmark that you said, and Louisville Water is spot on. I mean, they do a wonderful job of regulating it. But I think this was lowered from recommended 1.2 maybe about a decade ago, and I'm not 100% sure of that. But several things that I read cited that. So I hope that answers your question.
Yes, thank you.
Sure.
Anybody else? You know, at this conference, I had the opportunity to chat with a dentist from Utah, and he was, and he learned, he was trained with the former, guidelines, and he said, but even if I didn't want to advocate for fluoride, Utah doesn't add fluoride, or it was the first state in the U.S. to remove fluoride from water. And he said, I could tell you as a dentist who was from Utah and who was not, because,
Yep.
and probably it has to be related to age and exposure, but considering the other options, dental hygiene, that it's more upfront to the minds of the population, even for low resources populations, but fluoride in toothpaste, fluoride in mouthwash, and just highlighting the importance of topical effect, then I think for me, it's a no-brainer. But anybody else before we say thank you very much to Dr. Ransdell? Thank you so much, Dr. Ransdell. This was an eye-opening, very well researched, and a very good presentation.
Thanks for the opportunity.
Thank you so much. So now we will move to our updates and reports. Deputy Mayor Nicole George has had a previous commitment, so she had to leave our meeting. She will send any information if needed, but not to now. Family Health Centers, now I yield the floor to Dr. Bart Irwin. And you are muted.
I'm sorry, yes, I was having microphone trouble there for a minute. I have a few updates regarding the federal government. I'm happy to announce that so far that Family Health Centers has been financially unaffected by the government shutdown. And if it doesn't go too long, we think we'll be in good shape. So that's good news. Wanted to mention too that in mid-September, Thomas Ingalls, who's the administrator for Health Resources and Services Administration, HRSA, issued a letter and a policy priorities to HRSA programs, including qualified health centers. The document states that HRSA will use funding to assure that community health centers and other programs don't run afoul of the administration's policies and priorities. I won't go into all of those, but I will mention one that particularly affects family health centers, or could. Doing so could cost a health center its federal funding. There are several federal priorities mentioned in the 5-page document. At this time, Family Health Centers is at very low risk at losing any funding, with one exception, and this has to do with housing and urban development funds that Family Health Centers receive. We're at greater risk to our permanent housing program. We receive about $1.5 million from HUD to provide permanent housing support, a medical respite program, case management, and other related services for persons who are homeless. At highest risk are the permanent supportive housing program. Family Health Centers uses a housing first approach to house individuals in permanent housing. The administration does not like a housing first approach. So, but we've been very successful in using that. We have 110 permanent housing vouchers, and we've had a 97% success rate of housing people. And what does that mean? That means persons who were placed into housing, 97% either remained in that housing or moved on to other more appropriate housing or for them. So the success for housing first programs that are supported by case management are very successful. So the administration seeks to turn permanent housing dollars into transitional housing dollars, which means there would be a 2-year limit for any persons placed in their own apartment and supported by HUD funds and by Family Health Centers. So we're predicting that at the end of a period of 2 years, that most of those persons who are in permanent housing that lose that funding support will again become homeless. So the situation does not affect Family Health Centers alone. It affects housing and urban development permanent housing programs across the United States. So we're watching this change very, very carefully. I don't know that anything is in place yet, but that's the direction that the federal government is heading. And we will continue to advocate for permanent housing rather than transitional housing. So that, any questions? Okay, we'll
Thank
keep
you for the
updated.
information. Thank you so much, and keep us updated. My apologies, I skipped the director's update. Now I yield the floor to Louisville Metro Public Health and Wellness Chief Health Strategist, Ms. Connie Mendel. I'm sorry, Connie. The floor is yours.
No worries. Good morning. It's always great to meet with our board. You should all have, excuse me, you should all have a copy of the director's report. Please review that at your leisure. I'll go over some of the highlights. The first of which is that we did release the suicide fatality report. We had a great session last meeting highlighting some of the portions of the report. So you all have also some of the key findings and a link to that report in the letter that Ms. Glenn shared. So I will go ahead and go over a few of those quickly. Sorry, again. So this is a comprehensive suicide fatality report for Louisville and Jefferson County from 2019 to 2023. And it just, basically some of this we already know, but it's great to bring in up and share that there is an urgent need for collaborative community-wide action. So some of the key findings are that men are at an increased risk for suicide. In 2019, 67% of our suicide deaths were among men, but from 20 to 23, that number rose to almost 80%. Not surprisingly, firearms are the most common method. 57% of deaths, suicide deaths, involve the use of a firearm. So that just further emphasizes the importance of reducing access to these lethal means. Suicide affects more than just the individual. Nearly a third of the cases involve someone else being present at the time of the suicide or immediately thereafter. So that included family, friends, bystanders in public spaces. So what that means for us is it calls that additional help is needed for those individuals, for those family members, friends, and others that are also affected by the suicide. There were also rising disparities identified. Suicide deaths among Black and African American individuals increased 127% from 2020 to 22, and deaths among Hispanic and Latino individuals doubled from 19 to 22. And the last highlight I'll share is the report did identify occupational risks. So the top 5 occupations among suicide deaths were those around construction, transportation, material moving, production, food service, and sales related fields. So all of this to me, I mean, it's always heartbreaking, but it also sobering. This report is a call to action to our community. We need to talk openly about mental health, reduce the stigma around suicide and mental health, and ensure that help is available. There are some resources listed in the report, including the 988, can't say that enough, the 988 Suicide and Crisis Lifeline. So you can call or text. There's also the 7 counties crisis line. There are firearm locks available through the Louisville Metro Office of Violence Prevention. And also, we need to promote and provide more training opportunity, whether that's question, persuade, prefer, or we like to say QPR. And then there's also youth mental health first aid. So please review that, share that, and consider ways that you and others can be part of the community's response and how we can reduce the suicide deaths. Again, super sobering. It's hard to move on to the next topic. But the other thing, one of the other items listed in the report is we are seeing more West Nile cases than usual. So I know this morning it was chilly, which was nice. Mosquitoes are still active this time of year and will be active until we have multiple days with highs in the 50s. So please encourage your friends, your patients, your coworkers to continue to use insect repellent when you're out and mosquitoes are active, and wear long sleeve clothing. Do everything you can to prevent mosquito bites. September was National Healthcare Fraud and Prevention Awareness Month. There's some really good tips in the report to help prevent fraud and including Medicare fraud. So please review those, share those. And lastly, I cannot end a fall report without reminding everyone that respiratory virus season is here. So our local healthcare providers are beginning to see flu cases. COVID, we continue to see throughout with spikes and dips, and we're seeing RSV. So please encourage and get your vaccines against these illnesses. So COVID-19 and flu vaccines are available for everyone 6 months and older. COVID-19, flu, and RSV vaccines are recommended during pregnancy. If you're unsure of what to get, please talk to your healthcare provider. And there's also a link to the Kentucky Department for Public Health guide for fall immunizations. Really great information included there. And also the recommendations from ACOG, the American College of Obstetricians and Gynecologists, and the American Academy of Pediatrics. So thank you. And I yield the floor back to you, Madam Chair.
Thank you very much. Ms. Deliner has a question for you, Ms. Denny.
Certainly.
I put it in
Deliner?
the chat.
Oh,
I just
okay.
wanted to know if there were any commonalities with these professions. They're not the highest stress areas, and so I found that very interesting in the report on suicide.
You know, and it's a really good question. And I guess stress would be dependent on what else is going on in your life. So when we look at the work around, you know, the service industries, obviously, and others, these aren't the most high paying jobs. So, so I mean, that also could play a part, you know, into the stress and the workload. But those were determined to be the highest number of suicides related to those were the top 5 occupations. But suicide, as we know, can affect everyone, every occupation, or, you know, unemployed, retired thereof. So those are just indicators of those aren't traditional jobs that we typically link to suicide. So it is also a call to those employers to provide training, resources, and, you know, recognize the signs. But yeah, you're correct. Everyone is affected by suicide.
Ms.
Anybody
Mandel,
else? Yeah.
yes. In your report, you stated Hispanic Latino doubled from 2019 to 2022. Do you have specific numbers for that?
Those are included in the report. I can pull it. They were thankfully relatively low, but it was concerning that those numbers did double. And if I can put the actual numbers in the chat, but I also encourage you to review the full report. It's not long. I think our team, in conjunction with other local university and government nonprofits, I think, did a fantastic job.
And the report is linked into the director's report. So just go through the director's report, and you're gonna find the links necessary for the report.
Okay, yeah, I see it. I was following the report. I just saw the information. Also, do you have this information in Spanish for the crisis line? Do you know if there is information in Spanish?
The 988, as Ms. Robinson shared with us and her presentation for August, there is for the Commonwealth and so forth, and the same for Louisville area. There is information in Spanish promoting the 988, and there is a line with access to Spanish speaker counselors.
And the reason I ask is because I do outreach for Gilda's Club, and I was in Southern Indiana, and Life Spring Health System presented me with a brochure in Spanish for the crisis line. So I was wondering if we have anything for Louisville in particular that I could get a hold of, and I can also pass it around when I go and do outreach here in Louisville. And but okay, thank you.
Yeah, we can share that information with you. Go ahead.
Well, and I was just going to chime in that 7 counties has almost all of their information in Spanish as well. Bridie Harris, who's our outreach person, can easily help you obtain that information and circulate that. I will comment. So first of all, thank you very much, Connie, for highlighting this area. Obviously, as the medical director of 7 counties, I have a vested interest in this. For the Board of Health, I would just comment, you know, if you look at the research that was coming out of Cornell University, we can think deep thoughts about the all of the different characteristics. But the two most important things is one, that as healthcare providers, we ask about suicide at every visit, and we follow up with individuals that either don't show up with appointments, or we make contacts, what Cornell calls caring contacts. And these two activities have consistently shown the greatest impact in decreasing suicide rates. And it's something that 7 counties adopts. We move toward actually the idea of a zero suicide approach to the patient population that we treat. And those two functions, you ask about it at every encounter, and you do caring contacts with the people you have contact with, have some of the best research about lowering suicidal ideation among the individuals that we see. And it's something that everybody on this call can do. And Madam Chairwoman, I know that we're short on time, so I'll keep my comments there.
Thank you so much. Thank you so much. Now we pass. We go to the healthcare coverage and outreach. Now I yield the floor to Ashley Shoemaker. Ms. Shoemaker.
Yes, I wanted to share some important open enrollment dates. Medicare open enrollment runs from October 15th through December 7th. The Marketplace open enrollment is November 1st through January 15th. And there is no open enrollment for Medicaid. Individuals who qualify for Medicaid can enroll any time during the year. For Marketplace plans this year, you may have seen in the news that the Affordable Care Act enhanced tax subsidies are set to expire at the end of this year. So consumers who are enrolled in Marketplace plans will see their premium prices increase unless action is taken by Congress to extend those enhanced tax subsidies. In the state of Kentucky, we are estimating that costs will rise on average $100 a month. Some people, though, could see their premium costs increase significantly more than that, especially older adults and those closer towards the income cap of 400% of the federal poverty level. So that means that individuals with income over about $60,000 or couples with income of over around $82,000 will no longer be eligible for these tax subsidies. We encourage everyone that is currently enrolled in a Marketplace plan to shop their open enrollment to see what options are available, and if there's one that better suits their family's needs. I also briefly want to mention the Medicaid renewals for children that are ongoing. We have seen a lot of success with those. We're a few months into it and have seen renewal rates in the upper 80%. I think in August there's an 88% approval rate for child renewals. So that is also a great success. Hopefully we continue to see that trend continue. The next coalition meeting is scheduled for Monday, October 13th at 4 o'clock. Does anyone have any questions?
Just that the panorama looks bleak for the whole community. Thank you so much, Ms. Shoemaker. We don't have Dr. Ruth Carico or Dr. Anna Wang to share from the Immunization Advocacy Committee, so we go to our Community Advisory Board action items only, please. Do we have Dr. Stone from JCPS? I'm afraid not. From Greater Louisville Medical Society, Dr. Jeffrey Goldberg, are you in the meeting? Nope. Okay. For the Kentucky Nurses Association, now I yield the floor to Ms. Eleanor Manson. Ms. Delano?
Thank you. Good morning, everyone. I'll be very quick. I just want to let you know about a real talk with doctors and nurses about vaccines. It'll be on KET, October the 16th from 7:30 to 9 p.m. It's a call-in show. I will ask Ms. Glenn to send out the flyer for you all so that you can promote it in your communities and in your workplaces. It should be quite wonderful. We have 5 physicians and 2 nurses who will be participating, knowing that nurses are the most trusted profession in the world, according to the Gallup poll. I'm going to leave it at that.
Thank you very much. And we will share this information with the whole board afterwards.
Thank
Is
you.
there any old business? Dr. Scott, Dr. Randy was asking for particular wording to the question that you proposed. So if you could share that with us and we can send it and distribute it to everybody for the board afterwards. No old business. For new business, at this time, I propose that the Board of Health proceed into a closed session pursuant to KRS 61.810 1C to discuss pending legal matters. This will be brief, but it's necessary. Can I get a motion to move to a closed session? We have one. May I have a second? Thank you, Dr. Ransdell. So we move to go to a closed session. This is involving only the board health members and the lawyer and our coordinator. Everybody else, thank you so much for being here. We will record the opening session back, and we will add it to our public broadcasting for YouTube. Thank you very much. Please, board members, remain in this session. Catalina, please stop the recording. Thank you so much.